Welcome to this month's Fire Chiefs video message for the month of June 2017. This month I have Lieutenant Jamie Baltrowski from the EMS section joining me to talk about MCNIC, or Mobile Health. Welcome, Jamie.
Thank you. Thanks for having me.
So we've had some dialogue about this in other video sessions, and we've communicated Mobile Health 700 out to the field. Been ongoing since the latter parts of the fall. So what is Mobile Health, or what is MCNIC?
So MCNIC, our very long name, stands for Montgomery County Non-Emergency Intervention and Community Care Coordination. So basically our job is to target frequent users of the 911 system, typically anybody who's called 4 or more times within a 30-day period, and we will either do a home visit or we can refer them to other resources, because typically what we find is there's some kind of unmet need when our patients are calling us several times.
Right.
And so we'll connect them with a resource that can help with their issues.
And you said our, but it's really not fire rescue. We're not the only component in MCNIC. So who is
Correct.
the our in the equation?
The our is basically everyone, every care provider within Montgomery County, whether it's a private organization. There's a lot of grassroots organizations within Montgomery County, or our partners with Health and Human Services. Right. We're a very resource rich county, and but the problem is a lot of people don't know about those resources.
The interactions and ties between the resources. So as you outlined, it's the hospitals.
Correct.
It's the health care providers. It's the support infrastructure of Health and Human Services. And when you break out Health and Human Services, there's many different parts of HHS that play a role in their own individual components to MCNIC. Adult Protective Services is one, social services, aging services, many different variants within
Behavioral
HHS.
health. Yep.
Exactly. So when we say HHS, it's a big group of umbrella that covers them. So that's what is the key components and the key participants to MCNIC. So Mobile Health 700 started, like I said, back in the fall, but we did a trial, or we started with the grassroots activities of identifying our super users a little over a year and a half to 2 years ago.
Yes.
And what was the results of that, and how did that spurn the movement towards expanding MCNIC?
So in late 2014, early 15, we started with 14 patients, and we had just recently established our relationship with Health and Human Services. And we sent them a report of 14 names and asked if they knew any of those patients, if there were previous touch points with any of those patients. And with 9 of them, they were. And so they went to their group of folks and they increased services, reached out to therapists, folks like that. And the following month, we found that the call volume for that group of people had dropped significantly.
That was like 50%.
Yeah, and we the light bulb went off, and we said, wow, we must be onto something.
And these 14 were identified because they did what?
They were frequent users. They had called.
Right, called 911.
We hadn't even defined a number yet. They had just called a lot.
Right, now you're doing it on a monthly basis.
Yes.
And you're looking at a top tier of people who called 911 in a 30-day period.
Yes.
And again, HHS and Fire Rescue exchange those names. And as you alluded to there, but a lot of these folks were either already subscribers to some of these services or were enrolled but waitlisted.
Yes.
Pending to be brought into these services. And as that dialogue and collaboration worked, it was, okay, let's get this person, into that, because that's what may be needed or was needed to resolve an unmet need.
Yes, and a very big part of that is when we make referrals to Adult Protective Services. That's probably the most popular one for fire rescue. I think a lot of us feel, oh, it's going to be fixed. We made the referral to APS, but they only have so many resources, and so they can only take the worst of the worst cases. And so there's a large group of people that are screened out when we make those referrals. And that's a big piece of the patient population that we want to target, are the folks that APS can't reach or are waitlisted because they still have a need.
Right. So, how does the field provider, the folks on the EMS units, the folks that are running the calls, the folks that are interfacing with the resident who believe they are a candidate for, how do they do that referral for a resident, for a patient to McNick or to the EMS section?
So there are two different ways. The first one is on the eMeds report. There's the little check boxes at the bottom of the report. One of them says, does this patient require further follow-up from EMS? If you check that box, then we get an email, or I'm sorry, a report generated the very next day. It's, you know, a little bit of lag time. And we will research that patient and then make the appropriate referral. Then the second way is through the unit report. And there's a tab on the unit report that, for example, if it's a type of call that's maybe a service call that warrants a referral, but is an EMS report isn't going to be generated, we needed to have a second option. So we have the unit report, and they can fill out information that way.
Tab in the unit report or a checkbox in the
Yes.
PCR element.
Yes.
Okay. Or contact your EMS duty officer, telephone, but these two references within the RMS systems allow it to be tied to that data information. So
Yes.
when you get those referrals, what type of limitations are there to what McNick can do?
So we're really limited by the resources that we have right now within fire rescue. So it's myself and Lieutenant Robinson are the two main people that take in these referrals, and there's only so many hours in the day. So we certainly prioritize things. Sometimes we will watch and wait if it's a patient that maybe has only called a few times and it might be a temporary type of issue. And we can provide as much follow-up as we're able to. But these patients are really, really in need of lots of follow-up and lots of resources, and it doesn't get fixed overnight.
Right. So as we talk, there's definitely a desire, as with the Affordable Health Care Act, the keeping the community healthier, that we are, by this program, preventing the 911 call. That's one of the tentacles that McNick does, and that is strives towards our mission statement of preventing the 911 call by keeping the community healthy. And this is a pre-response EMS care element, because we're taking care of the community and this population's needs for social care or medical care or advanced interactions that allows them to not utilize the 911 system as their safety net.
Yes.
To deal with whatever the situation may be.
And I think a really important thing also for our providers to take note is that there are some of these folks that are living in squalor and their house is a mess, they're hoarders, but they're competent adults and they're allowed to make those types of decisions. And so we see a lot of frustration of, well, why can't you help this person? Because they're allowed to make those types of decisions. And so that is also one of our big limitations, is that sometimes people don't want help and we can't force ourselves on them.
So as we work with community paramedicine, which is kind of a nomenclaturally bad phrase, but as this is McNick and keeping the community healthy, this is a means by which we work towards not requiring the 911 dispatch to support that. And tell me about Mobile Health 700 and what you're doing right now with Adventist, Silver Spring, and how that's interacting and what may be on the future.
And so, we have Adventist and also recently Shady Grove Adventist, as well as Suburban Hospital, and I think Montgomery General is pretty close behind. So they are providing us with a nurse through their population health departments within their hospitals. And we're running reports comparing their high utilizers versus our high utilizers. And we'll set up an appointment with the patients and go out with a nurse. They also have community health workers in some of those hospitals, and meet with the patient. We'll do a home safety check. All of our McNick providers, we have 15 of them, have been trained by Jim Resnick's community outreach program. And so we'll do the home safety check. The nurse can reconcile the medications of the patient. They'll do an assessment. We have a self-assessment that we go through with the patient to see how they feel about their health. And then the conversation can just really go whatever direction it needs to go, depending on what the needs of the patient are, because each one is so different.
And so right now you're out there about more than one day a week, or?
It's growing very quickly.
Right.
I would say at least once a week. We have a few providers now that have their own patients. So we've done 2 or 3 visits a week now.
Okay, great. And that's the dynamic that we're dealing with because of the 6 hospitals and the 4 different hospital parent organizations and how they are unique in their own. They all are interested in and know that this is something that they need to be engaged with as well.
Yes.
But with the Adventist, with Holy Cross, with MedStar, with Hopkins, we have just those different nuances between the parent organizations of our hospitals.
And they're all in different levels of being ready for this type of
Exactly.
program.
And that's why it's making it more complicated or just a little slower to kick out. You talked about 15 people who are McNick providers and who received the training. What if someone's interested in becoming a member of your cadre or get that training? How do they go out about expressing that interest?
So they can certainly send myself an email.
Okay.
We originally started with, we had an open application process, and we asked for folks to just write a letter of why they were interested. We had 20 positions available, and we had 40 applications. So we had everybody that applied was overqualified. I had some really good applications. So as it stands right now, I want to be able to go through our list of current folks and be able to assign patients to them and get them up and running, really before we add any new people right now. But I imagine as our hospitals get on board and things really ramp up, we're going to need to add people.
And that's one of the things that there's some background work ongoing right now. We've talked about McNick and the interactions jointly between the HHS director, myself, and the executives staff about how this is a program that we could expand in small segments and make great strides with our population base. Got some promising prospects upcoming. Not right at the moment, it's a little too early to articulate, but yeah, as you said, we're borrowing you and tagging Ashley and borrowing the other providers from field services. We need to get some folks that are full-timed to this. One of the key points that some folks may not be aware of is that social worker dynamic that needs to be a case manager component to help with the HHS side of it. And that's something that HHS is totally supportive of, but they need the FTE or the full-time, a person to be able to do that. And that's why we're collaborating together to work on those expansions. It's really cool. Can you touch on the grad student interaction that's helping here?
So we've been speaking with University of Maryland at Shady Grove and about adding an internship for their social work program. So we would have a second year master's level social work student that would be part of our team. And typically that it's good at the master's level because they already have some work experience behind them. So the hurdle that we had to overcome with that was that student needs a social worker to oversee them.
Right.
So we're working on that right now. It sounds like, at least as far as University of Maryland goes, we would be able to put this online next fall.
Okay.
And we're already having prospective students that have contacted us to say we're interested. So that's really exciting. And a reason of why that's so important is, as we're learning very quickly as our McNick providers get assigned to patients, is that it is so time consuming, and our providers are becoming the social worker because there's so many different avenues of where these patients need help, that it may even be that one patient per provider is a big enough caseload right now.
And we anticipate, as you said, there was a 50% call reduction in just the first 14 or just the first handful of folks that we interacted with. We anticipate, being able to ideally in our next phase, maybe manage about 150 to 200, enrollees or our participants.
Yep.
And that could have the impact of a couple thousand call reductions.
It could.
And as we know, we're getting busier with traditional 911 calls, roughly 3% a year, and we're 90-some thousand EMS calls and 71,000 transports. One of the main abilities that this is doing is it's abating the rate of rise. We weren't going to turn that rise down or make it go in a reduction process, but if we make that rate of rise maybe only 1%, because we're taking these users and providing them the other care they need so they don't calling 911, that allows us to maintain the unit capacity we have with the anticipated increases that we do look forward to with new units, new stations, and still have more capacity or elasticity to deal with the sick of the sick, and that's why this is definitely a benefit towards keeping the capacity that we have.
Yeah, can I give you a few stats?
Certainly.
Okay, so that was a great segue into my numbers here. We have had since January 1st of 2016, 383 referrals from our field providers. That's a lot of referrals. We have made 69 APS referrals, and of those 69, only 22 of those have been screened in. So that goes
only
back
a third.
that goes back to what about the rest of those people that haven't been screened in? They still need help. And we currently have 107 enrolled patients. And so by enrolled, as you were just speaking to increasing our capacity, when we consider somebody enrolled, that means that we've referred them to a resource of some type.
Right.
But we always continue to follow them. We follow up with whoever we referred them to. We keep them on our radar. And also in that 107 includes now our home visit patients as well. And so we're rising. We started with 14.
Right.
The following year we had 33 enrolled patients. And now we have 107. So things are moving quickly.
And they are, there's no doubt. What can the field providers, the men and women in the units do other than doing the checkboxes and referral? Is there any other key points that you can reference them to, resources, or reference them to learn more about McNick or be able to provide the right referral to the folks when they're out there? So
there's a couple things. Thanks for asking that question. The first thing is to provide as much information as they can. So especially when they're filling out the unit report box, if they can get a phone number, if they can get a name of a family member, anything that would help us reduce the detective work that we have to do would be extremely helpful. So that's different than our normal data collection for the patient. We're looking at the patient's information and that. So when we're dealing with someone like this, where we're either doing a unit report referral, as you're asking for, family member, point of contact, the phone number at home. Especially in the service call types, because typically an eMeds report isn't generated. Right. So we have nothing to go on other than the CAD remarks. We can always look up the phone number, but sometimes that phone number doesn't get us anywhere. Right, okay. That's good points. And the second point would be that we also are seeing lots of errors in the eMeds reporting, because there's 4 or 5 check boxes and people just check. And so we have to go back and ask, was this a correct referral? Did you mean to do this? Was it a mistake? And it's time consuming. So if our providers could just pay a little bit of attention to only check the box if necessary. Okay. Anything else to add about McNick or mobile health? I'm just thrilled to hear some of the success stories. I love hearing from our field providers when we've been able to help somebody that they've been running over and over again. I did want to speak to some of our numbers. Again, we had 1,800 people that called 911 4 or more times.
4 or more.
4 or more times that accounted for 12,584 calls.
Right.
That's an average of 7 calls a person,
Right.
and 5 EMS units.
Right. And that's where we're talking about the fact of getting that person's, that group of people to reduce their calls again by half, as we have already experienced the capabilities of.
Mm-hmm.
We're taking 12,000 calls potentially down to 6,000 calls.
Mm-hmm.
You know, even a further reduction that could be in the 4,000s and 3,000s.
Mm-hmm.
You know, that's just, you know, at almost equal to half of a new unit. So there's no doubt that we can see that we can reduce the numbers of 911 dispatches by having these folks have the other support they need.
Mm-hmm.
So that's the numbers that help the people watching the video understand why we're saying to the council and to executive and other parts within the county government, this is why we need to do, you know, McNick and push that forward.
And our providers are doing such a good job out there. We hear time and time again from, you know, Mrs. Smith, who we pick up off the floor once a week. Well, those nice men and women told me I could call 911 whenever I needed to. We're always here to help,
Mm-hmm.
and that's really great. But we need to find her a better way.
And there's no doubt that that's one of many different things influence that patient's falling or
Mm-hmm.
influence that mobility issue that creates that. And that's not always one point. It may be multiple points that get that fixed.
Mm-hmm.
So, good deal. So we just had a rash, and I'm going to be using that description. And it's summertime. It is very hot outside at the moment. It's school's about ready to end, or has already ended in most of the communities around us. Tragically, yours today, as an example, was 4 drownings. 4 drownings or near drownings, just 3 within Montgomery and 1 in DC. And this is just another influence where attention to detail and safety factors are critical. We call lifeguards, but what are lifeguards? Are they babysitters, or are they lifeguards, or are they a safety net? You know, I like to prefer that they're called a safety net.
I agree.
They're the safety net to the adult supervisor who is responsible for the children.
Yes.
And it's that adult supervisor who needs to be attentive and attending to those kids as they are swimming, be it a pool or a creek or a lake or whatever. Mm-hmm. You know, so there's a lot of importance to how tragically the numbers of unattended drownings and or toddler, you know, deaths due to drownings are amazingly high, and how quick it can transpire. Yeah. So it's a topic that we dealt with significantly yesterday, and it's one as school finishes getting out throughout the region, and we deal with the 100 days of summer per se, and it's going to become more and more prevalent, regretfully. You know, so I really ask, you know, everyone to, as you deal with your own family members, as you deal with your friends and families, make sure you're, you know, high level of attention to that, and let's be ready for and be able to react to and respond to those incidences. And great work done by the 2 Montgomery County crews yesterday that had near drownings or drownings with some loss, as well as you know, conversive patient. So
absolutely. Yeah.
So definitely good work. So and that's you know, a thing that there's tons of great work every day from the men and women out there, and that was just another example of good work done by the folks just yesterday. So thank you for coming.
Thank you for inviting me.
Again, plenty of work to be done. A lot of expansions hope to be on the future with McNick and mobile health. And definitely keep having the folks fill out their unit report narratives, and as well as their checkbox on the PCR. So,
and please just be patient with us because we're working on it.
Nope. I appreciate that, and patience is how we get little steps forward and how we get things accomplished. So, good deal. Thanks, Jamie, for coming this month. And as I already hit, the dog days of summer, as I would say, are here and upon us for sure. Hydration, we talked about that the beginning of the week. When you come to work, it's too late to start doing hydration. As you start your duty shift or your standby night, you have to have already been hydrated and be ready for this temperature. It's going to get hotter. June is here, but July is coming. So the right type of fluids, water, a little bit of sports drinks, but try to alleviate the caffeine and focus on your consumption rate so that you're ready to go. The average firefighter in a 30 to 45 minute fire activity can lose about 2 liters of body fluid, 2 liters of water through the firefighting activity. So come to work, be ready, but at the same time be safe. Take care. Thank you.